Good evening, dear professors and colleagues. It's always an honor and a pleasure to join this annual prestigious meeting. My topic today is about atrial fibrillation in heart failure, from medical treatment to catheter ablation. My name is Ahmed El-Damaty. I'm a lecturer of cardiology, Cairo University. I'll start off with a quick introduction about AF being one of the major causes of stroke, heart failure, sudden death, and cardiovascular morbidity worldwide. Atrial fibrillation is independently associated with a twofold increased risk of all-cause mortality in women and 1-point-fold increase in men. A minority of these deaths are related to stroke, while sudden cardiac death and death from progressive heart failure are more frequent. Evidence accumulated across the years, and this is an important slide that I have came across, showing evidence along different axes of management of atrial fibrillation. So the green axis speaks about the preventive measures that we take to prevent atrial fibrillation, namely the use of beta blockers, ACI, ARBs, MRAs, in the prevention of atrial fibrillation in patients with heart failure and the reduced ejection fraction, till we ended with the stage of the RACE-3 study that we are going to talk about in few minutes. The blue axis here is about stroke prevention. We started off with warfarin being superior to aspirin, and then we came across NOACs, which was proven to be non-inferior to warfarin, and we ended up by the fact that NOACs are safer and slightly more effective when compared to warfarin. The red axis here started off with pulmonary vein isolation as an intervention that can suppress atrial fibrillation. It moved along till we reached the stage that it is better than antiarrhythmic drugs and that it can be used alone to maintain sinus rhythm without resorting to lines and cafes and so forth. And we eventually reached the point where we used alternative energy for achieving pulmonary vein isolation, namely cryoenergy, which was proven to be as effective as radiofrequency energy. So this evidence made us reach the point where we have a 4S scheme for structured characterization of atrial fibrillation endorsed by the European Society of Cardiology, where you need to think about the stroke risk and figure out whether this patient is at high risk of stroke or not, given his SHADS score. You need to think about the symptom severity based on the EHRA symptom score. You need to think about the severity of the AF burden and what's its temporal relation to time, whether it's paroxysmal, persistent, or long-standing persistent. Last but not least, you need to think about the substrate. Is there comorbidities? Is there an atrial cardiomyopathy evidenced by atrial enlargement or atrial fibrosis that can be detected in imaging techniques, particularly cardiac MRI? And when you think about your 4S scheme, you then go to your ABCs where you start treating atrial fibrillation, A being a focus on the anticoagulation to avoid stroke, B being better symptom control, whether by achieving better rate control or adopting a rhythm control strategy. And last again, but not least, treating the comorbidities such as hypertension, diabetes, hyperlipidemia, and obesity, which are proven to result in better outcome when they are treated. So focus on some treatment strategies. We're going to go ahead for the next few slides. The first strategy that I want to talk about is the rhythm versus rate control strategy. So the AFFIRM study is a time-honored study that laid the concept of the fact that rhythm and rate control does not make much of a difference. So in this study, about 4,000 patients were randomized to a rhythm control strategy versus a rate control strategy. And the primary endpoint was looking at the cumulative mortality. And in a matter of fact, the investigators did not find a significant difference between both arms. Actually, the rhythm control group had more hospitalization, more complications that are related to the adverse drug effect, and more torsade de pointes as well as bradycardias. So this concept is now challenged by more than one study, the most important of which, and the one that is pertinent to our presentation today, is a study that is related to atrial fibrillation and heart failure, namely the CASTLE-AF study. In the CASTLE-AF study, about 3,000 patients were screened for eligibility. The investigator ended up randomizing about 400 patients to two arms. All patients have to have symptomatic paroxysmal or persistent atrial fibrillation, impaired ejection fraction that is less than 35%, and a device that allow home monitoring, whether an ICD or a CRT defibrillator. The randomization arms were the conventional therapy versus the ablation therapy. The endpoint that was looked at was the all-cause mortality as well as worsening of heart failure and admission to hospital. The investigators found, so this is again one of the baseline criteria. We're gonna quickly emphasize the fact that these patients had an impaired ejection fraction in both groups. So the median was 32 in one group and 31 in the other group. So in this study, the investigator found that the endpoint was significantly better in the ablation arm. The ablation, being a rhythm control strategy, showed a better outcome when compared to medical treatment. This data was proven to be significant also when the investigator looked at death alone or hospitalization for worsening of heart failure alone. Each finding was statistically significant, and the hazard ratio showed a better outcome in the ablation arm. So the investigator concluded that catheter ablation for atrial fibrillation in patients with heart failure was associated with a significantly lower rate of composite endpoint of death from any etiology or hospitalization for worsening of heart failure when this was compared to medical treatment. So this is another clue that we could be heading to the era of a rhythm control strategy, but not resorting to drugs that could have deleterious effects, but for a procedure that is effective and relatively safe. The CASTLE-AF study had its strong impact on the guidelines that was published in 2020 that stated that patients with paroxysmal or persistent atrial fibrillation and heart failure with reduced ejection fraction could resort directly to a catheter ablation if they would agree for it, knowing the benefits and the risks, and that's a class 1 indication. You don't have to fail an antiarrhythmic drug before going to the option of catheter ablation if your patient has a reduced ejection fraction, and that is based on data from the CASTLE-AF study. So the other strategy that we need to talk about in this context is the lenient versus strict rate control if you adopt to go for a rate control policy. This is addressed in the RACE-2 study, which studied the lenient versus strict rate control in patients with atrial fibrillation. In this study, the investigators compared lenient rate control, which is heart rate at rest that is less than 110 beats per minute. In a matter of fact, most of the patients ended up having a heart rate less than 100 beats per minute in this arm, versus the strict rate control, which targets a resting heart rate that is less than 80 beats per minute and with moderate exercise that is less than 110 beats per minute. The investigators found no statistically significant difference in the primary outcome, which was a composite endpoint between the strict control versus the lenient control group. What is important to mention here, pertinent to this presentation, is that the investigators appreciated that patients with impaired left ventricular function have to be followed rigorously for deterioration of the left ventricular ejection fraction if they adopt a lenient control policy, being cautious about the development of tachymyopathy. The third strategy that we need to talk about here is the preventive strategy. Can we prevent the occurrence of atrial fibrillation? And the answer is definitely yes, based on the RACE-3 study, which randomized patients who have early symptomatic persistent atrial fibrillation for either a conventional therapy or an upstream aggressive risk factor modification for 3 weeks prior to cardioversion. This upstream aggressive risk factor modification involved mineralocorticoid receptor antagonists, statins, ACE inhibitors or ARBs, as well as cardiac rehabilitation that involved physical activity, dietary restrictions, and counseling. Patients were followed along for 1 year, and a 7-day Holter monitor was performed at the end of the follow-up, looking for atrial fibrillation. These are the baseline characteristics, and it's important to emphasize here that the left ventricular ejection fraction in this study was less than 45% in about a third of the population. When we looked at the outcome, the primary outcome, patients were sinus rhythm in 75% of the case if they adopted the upstream risk factor, aggressive risk factor modification limb, while 63% only maintained normal sinus rhythm at 1 year if they were in the conventional arm, and that difference was statistically significant. The investigators came up with the fact that upstream therapy, including treatment of risk factors and change of lifestyle, is effective in preventing the occurrence of atrial fibrillation, and it is feasible as well. Again, this patient population included about 30% of the patients in both arms having an ejection fraction that is less than 45%. So your patient with atrial fibrillation and heart failure would certainly benefit from aggressive risk factor modification and lifestyle changes in terms of recurrence of his atrial fibrillation down the road. The last strategy that I need to talk about here is AV node ablation and implantation of a CRT, which is a strategy that we sometimes are obliged to perform when all other measures fail. So your patient had 3 AF ablation procedure, it didn't work, He is on medical treatment, on the maximum medical treatment possible. His atrial fibrillation cannot be maintained in sinus rhythm. And even despite the rate control medications that you are keeping him on, his atrial fibrillation rate is still high. So this is the kind of patient whom you could be obliged to use this strategy in. So this is looking at data from the MADIT CRT study, and we need here to look at the red line, the purple line, and the light blue lines, which are lines where biv pacing was achieved in less than 90% of patients of the time. Biv pacing was achieved in 91 to 96% of the time. And the blue line here, in which biv pacing was achieved in almost 100% of the time. And looking at the probability of heart failure and death here, you can clearly see that when you achieve biv pacing in more than 97% of the time in your patient, you would have the best outcome. The problem is sometimes this cannot be achieved in patients with atrial fibrillation only with drugs. This is a study here where the investigators looked at the total mortality as well as the cardiac mortality in patients who were in normal sinus rhythm, patients who were in atrial fibrillation. They had CRT, of course. All three groups had CRT, but they were treated with drugs, versus patients who had atrial fibrillation who were treated with AV node ablation. And you can clearly see here that the total mortality as well as the cardiac mortality was similar in the arms of patients who were in normal sinus rhythm and those who were in AF but they had AV node ablation. Patients who did worse were patients who were in atrial fibrillation and had only medical treatment to control their atrial fibrillation. This, of course, emphasizes the fact that rate control have many limitations in this group of patients, and you might not be able to achieve your 97% biv pacing only with rate control. So again, this is looking at the same data differently. So this is looking at the left ventricular end diastolic volume and see how it behaves with significant reduction, denoting improvement in patients who were in normal sinus rhythm and in patients who had AV node ablation, while the group who had only drugs to control their atrial fibrillation did worse in terms of the reduction of the end systolic volume. I will wrap up with a quick case. This is Mr. RS with a 65-year-old gentleman who has ischemic cardiomyopathy, ejection fraction of 35%, and a left atrium of 60 millimeter. He has an ICD for primary prevention of sudden cardiac death. He developed long-standing persistent atrial fibrillation that is difficult to rate control and caused recurrent inappropriate shocks from his ICD. So the question is, what would be the next best step on his management based on the available body of evidence? And the options are AFib ablation, AV node ablation, an upgrade to a CRT, or up-titrate his medications to the maximum tolerated doses, and perhaps add amiodarone for rate control. The point is, all these treatment options could be used. You need to weigh the risk against the benefit of each treatment modality and to figure out what treatment modality would suit your patient. Several factors needs to be considered. Patient-related factors, the years that he has been in atrial fibrillation, the degree of myocardial impairment that he has, the size of his left atrium, which is a very important point that needs to be considered. You have also to consider physician and center-related factors. How much volume do you do per year in terms of atrial fibrillation ablation? you need to answer this question. Do you think that with an atrial fibrillation ablation procedure, you can maintain this particular patient in normal sinus rhythm or not? If the answer is yes, perhaps going to a rhythm control policy using AFib ablation or medications can be resorted to. If not, rate control, whether by medications if can be achieved, or with AV node ablation and CRT implantation, perhaps could be the only answer if this is the last resort. So as a take-home message, I want to emphasize that atrial fibrillation and heart failure very commonly coexist. Medical treatment and catheter ablation remains to be the possible alternatives of therapy. There is growing evidence that praises the future role of catheter ablation in maintaining normal sinus rhythm. AV node ablation and CRT implantation remains a possible alternative for cases resistant to medical treatment and AFib ablation.